Hi, my name is Brian Hom. I attend Fairview High School, and I'm a participant in the Science Internship Program. The title of my project is How Fast Are We? Throughput Times for Admissions from the Emergency Department. Overcrowding and slow patient throughput is a major problem in hospitals throughout the U.S. Patient throughput is a systematic process of attending to patients from the time they walk into a medical facility to the time they check out for discharge. There's a dramatic rise in emergency department wait times and diversions in the U.S. Over the past 2 decades, the number of emergency rooms have decreased while the number of patient visits have increased by 35%. Capacity issues usually arise in areas of the hospital where demand fluctuates. In 2008, the Center of Disease Control reported the average time that patients wait to see a doctor in the hospital emergency rooms grew from 38 minutes to 1 hour between 1996 and 2006. Emergency department visits in the United States increased from 90 million to 119 million from 1996 to 2006 and is still growing. This cartoon illustrates the overcrowding issue with patient bunk beds in rooms since emergency departments are overflowing so much. Overcrowding and patient throughput issues need to be resolved for several reasons. Overcrowding and slow patient throughput compromises patient safety, reduces hospital revenues, and affects staff and patient satisfaction. The quality of patient care is jeopardized because the amount of patients outweighs the availability of resources. The level of stress for the staff increases, prolonged pain and suffering by the patients, long patient wait times, increased transfer times for ambulance patients, and inconvenience and dissatisfaction for patients and their families. There are several indicators of overcrowding. The number of hours a hospital is on diversion status is one indicator. Diversion status is a bypass status where emergency medical services are notified that the hospital is full so patients are not brought there. Another indicator is the number and length of time patients are on hold in the emergency room after being admitted. The proportion of patients that leave the emergency room before having a medical evaluation since they are tired of waiting is a third factor. The hypothesis for my project is that if data is collected about the average time taken between key steps in the patient throughput process, which are arrival, disposition, bed ready, report, and transfer, in the adult emergency room, then a baseline will be developed that can lead to future research on possible improvements to the patient throughput process, and the staff can focus on improving on specific areas that may slow down patient throughput. The methodology of my project is I conducted a retrospective study conducted on the throughput times for normal adult admissions, so no cardiac arrest or stroke, in the emergency room of Fairview Hospital. 300 patient charts were examined using the Epic system. 10 charts were taken each day from June 12, 2011 to July 4, 2011. The patients were chosen randomly based on when they were admitted, by day shift, which is 7 a.m. to 3 p.m., by evening shift, 3 p.m. to 11 p.m., and night shift, which is 11 p.m. to 7 a.m. The arrival time, disposition time, assignment/bed ready time, report time, and the time the patient went up to the floor were recorded. The amount of time in minutes was determined for each of the key points in the throughput process. The average time was determined for each checkpoint for each shift in each day. Staff from various departments were also asked about their opinions as to what slows down patient throughput. So this graph shows the average time from when the patient arrived in the triage to when they were admitted. Notice how the times in the evening were generally longer than the day and night shifts. This graph shows, graph number 2, this shows the average time from disposition to when the bed was ready. Mainly the day and the night shifts have the longer times than the evening. Figure 3 shows the average time from bed ready to report. The evening tended to have a longer time than the day and night shifts. Figure 4 shows the average time from report to the time the patient actually went up to the floor. And the times were generally under an hour, and the evenings tended to show the longer times out of the 3. Figure 5 shows the entire process in the ED portion of the throughput process. And the evening, which is the blue line, shows the longest times. So, results. The data can act as a starting point for further research regarding patient throughput. All the steps of the patient throughput process affect the times, but no one step is responsible. The throughput times for the evening are often longer due to a greater influx of patients in the evening. And according to the data, the time between when the patient arrives in the emergency department and when they are admitted to the hospital is typically the longest. In addition to examining the throughput times, I also examined factors that affect throughput by observing various departments of the hospital and asking nurses, technicians, and doctors what they thought affected it. Each department has their own factors that may contribute to overcrowding and slow patient throughput. According to a 2003 report on emergency room overcrowding by the U.S. General Accounting Office, they said the factor most commonly associated with crowding was the inability to transfer emergency patients to inpatient beds once a decision had been made to admit them as hospital patients rather than to treat and release them. These patients are known as boarding patients. They still require care and take up space, equipment, and staff time, so other emergency patients cannot be treated. Other factors are that copay is collected from patients after they are ready to be discharged. The IV contrast fluid that is required for certain tests takes hours to circulate the body. There's not enough staff on duty. Beds are not cleaned in a timely manner for the next patient. There's a limited number of beds that have telemetry. Discharge of inpatient beds are not occurring in a timely fashion. The emergency room is holding admissions until later due to other priorities. There's immense paperwork that requires time to fill out completely. Charting slows nurses down. Doctors do not make their rounds in a timely manner. The patient's ride is late to pick them up. It takes a while to explain medication and how to take it for patients. Emergency department patients tend to be older and therefore have more complex conditions which require more tests. And it takes time to receive results from those tests. The standard for admittance is also changing. And emergency department patients compete for available beds with scheduled admissions, such as surgery patients. This diagram shows where the inpatients come from in a hospital. There's a combination of emergency department admissions and non-emergency department admissions from transfers from other healthcare facilities and direct admission from clinics and scheduled procedures. After learning about factors that affect throughput, I examined possible ideas to improve it. One is simply to increase staffing. Others involve increasing capacity or efficiency, such as building a larger emergency department, focusing on increasing speed in registration and triage, improving efficiency outside of the emergency department, encouraging staff to discharge patients by noon instead of all day or any time during the day, setting up a dock and triage system where a physician is stationed in the triage and admits only the patients that need it while quickly treating those with less severe conditions, and assigning an area specifically for inpatient beds ready to be discharged because patients who are ready to be discharged often wait for hours just for their doctors to make their rounds. This occupies inpatient beds that need to be used. My recommendations for further studies, test several ideas on throughput improvement and see if they improve efficiency, use a larger data set to obtain more accurate results, and make comparisons to other area hospitals. So in conclusion, the purpose of this study is to develop a base that can be used for further research in the improvement of patient throughput. Improving patient throughput or flow will improve patient care and satisfaction. This data will help the hospital and staff gain insight as to what can be done to improve patient throughput. Many factors that affect patient throughput are out of the hospital's control. Improving patient throughput is important because it directly affects patient care, hospital revenues, and overall satisfaction of the patients and staff. A hospital functions as one team, and all the departments need to work together in order to resolve the patient throughput issue. And I would like to thank my mentors, Deborah Porter, Kathleen Chambers, and Laura Gartner, and Fairview Hospital and the Emergency Department, and the OCEI Summer Internship Program. Thank you.